today is, of course, our presenter, Dr. Andrea Furlan, who received her medical degree in medicine from the University of Sao Paulo in 1992, followed by internship and residency in psychiatry, also from Sao Paulo, and physiatry. Yeah, everybody gets that wrong. And I underlined it 3 times, from physiatry from Sao Paulo in 1995, a preceptorship in physical medicine and rehabilitation, also in South America from 1997, followed by her first fellowship in health services research at the Institute for Work and Health in 2002, a PhD degree in clinical epidemiology from the University of Toronto in 2006, and then a second fellowship in rehabilitation medicine from the Toronto Rehab Institute in 2008. Yet another person from the Doug Lee School of Deferred Gratification. He's currently an assistant professor at the University of Toronto, an associate scientist at the Institute for Work and Health, an adjunct scientist at the Toronto Rehab Institute, and a staff physician at St. Joseph's Hospital here in Toronto. Lots and lots of accomplishments. I was particularly impressed by multiple prizes for academic excellence. She is the principal investigator on an active grant from the PSI Foundation here in Ontario. She's got over 50 Medline articles, to the name of which 11 are first authored. She is a true guru when it comes to the use of opioids for chronic pain. She's a popular teacher as well as a protege to Claire Bombardier. Thanks very much for being here.
Thank you, thank you. It's my pleasure to be here. Let me see if I'll stay around here. And did you have a chance to get the handout that was outside?
Right here.
If you didn't, I have some copies here. I'll talk about this later. So again, thank you for inviting me to present here. And so it's a birthday party. As you see, we have balloons and celebration. Because this is, May 2011 is the first anniversary of the Canadian Opioid Guideline. And it was released last year, May 3rd, 2010. And we are trying to keep a momentum with the guideline. As you all know, guidelines, they don't change practice by itself. People publish guidelines, they're shelved, and they get some, media uptake and some celebrations, but it's hard to keep thinking about it and keep modifying behaviors, and that's what I'll be talking about. I'll briefly summarize what is in the guideline, but that's not the main focus of my talk today. If you want to know what is in the guideline, what the guideline recommends, really, this tool, the Opioid Manager, is a synthesis of what the guideline recommends for physicians prescribing opioids, for physicians' assistants, nurse practitioners, and pharmacists dispensing. And this was a tool that I developed at Toronto Rehab with a grant from the Ontario Ministry of Health through the AFP Innovation Fund. So the objectives of this talk are first to tell you about the dissemination, implementation activities that are going through all over Canada, because this was a Canadian guideline. And also, what are the things that we still don't know about opioids for chronic non-cancer pain? There are still a lot of gaps. And also do some marketing about the hospital where I work. Don is very aware of, we are trying to get some driving simulator at Toronto Rehab to study these drugs, especially opioids, but every medication that is prescribed for pain. We will have this capacity at Toronto Rehab, and I'll show you what we have there. Before I go ahead, I'd like to mention my conflicts of interest. I didn't make any slide because it's so simple, it would be blank. I don't have any conflict of interest. I never received a penny from any pharmaceutical industry, and I refuse to take. Not that they didn't try. They tried hard, but it's hard to say no. But I keep saying no because I think that's an important decision, and I'll try as long as I can. For the development of the guideline, because it was developed, yes?
Actually, can I ask you a question about that? How do they try? The structure of being approached.
That's another topic. That's probably 30 minutes talk. But how do they try? They try to ask me to give talks for physicians, basically, because this presentation is the second time that I gave this one. I got a prize at the Canadian Pain Society with this talk, but the other one that I talk about the guideline itself, I've been giving 50 times probably. and they want me to come and present to a group of physicians. They will pay my travel, they will pay a nice hotel, and they'll give me a very nice honorarium. It's usually, depending on where it is and for how many people, I can charge $5,000 for a talk. So I said it's hard to say no, but
Don, they clearly don't ask you.
Yeah. It's not that I'm so virtuous.
No, they just don't ask, do they?
And the guideline itself was developed by the colleges of physicians and surgeons of all provinces and territories in Canada, and NUC, who is the author of the guideline, they had the first policy in developing this guideline. We're not going to accept any money from any pharmaceutical industry to develop the guideline. It was all money from the colleges and from the federation of the colleges in Canada. However, to make a guideline like this, we had to invite experts in pain, in family medicine, pain experts, addiction experts, and of course, those 49 people who helped us to put this guideline together. They, by themselves, they had some conflicts of interest themselves, but this is all laid out. They had to disclose everything, and there is a document in the guideline. You can take a look and see who is who and where did they have received honorariums. So what is a guideline? So just a definition from the Institute of Medicine. Guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of the evidence and an assessment of the benefits and harms of any alternative care options. Why did I bring this definition here? It's because this guideline, the Canadian Opioid Guideline, really is not, it doesn't fit this definition, because we don't discuss any alternative care options for chronic non-cancer pain, which is unfortunate, because there are so many other things that work for chronic non-cancer pain, but the objective of this guideline was to solve a problem that the colleges were having, that physicians didn't have a document to guide them on how to prescribe this specific drug, opioids. So, unfortunately, we only talk about opioids in the guideline, and there are plans to develop other guidelines to treat chronic non-cancer pain more broadly, but this will be the future. So, as I said, the guideline was released May last year. So this is freely available, and the guideline is available at the McMaster University. They are now housing the guideline. They created a website for the guideline. Anyone can download Part A and Part B. It's free. It's 163 pages if people have time to read. Of course, we give for physicians, because CNAJ goes to every physician's desk who are associated with the Canadian Medical Association. So we wrote an 8-page summary of the guideline, the main recommendations, and hoping that the physicians would have more time to read the short version of this guideline. So what are the guidelines' key messages? This is the only slide that I'll be talking about. What is the guideline? And also you have the opioid manager. But the guideline talks about many things, many things. There are 24 recommendations to treat chronic non-cancer pain, things that physicians need to pay attention, to monitor, to document, especially because it's a guideline that is prepared by the colleges, and the colleges are the ones who give licenses to physicians and also remove licenses from physicians if they don't do things properly and safely for the population. But here, this is one slide that when I come to physicians to tell them what the guideline is about, I like to show this and say, if you remember this, you remember the whole guideline, because it's all about this. So always, when prescribing opioids, they should start with a comprehensive assessment, so knowing the patient, creating some relationship with the patient, knowing who the person is, where do they live, the social environment, the psychiatric comorbidities, their family, their work, knowing the patient. And this is to ensure that opioids are a reasonable choice and identify the patient's risks and benefits for that specific patient. And then the second thing is setting goals with the patients, because sometimes it's easy to prescribe an opioid, especially with a system that is so disjointed. In 2004, the OHIP partially delisted all physiotherapy clinics and chiropractic clinics. So physicians have difficulty to send people who have a simple low back pain to physiotherapy. It doesn't exist. OHIP doesn't cover, unless if you have a motor vehicle accident or you are an injured worker and you have double SIB, or physiotherapy in the hospital. But clinics only private. So physicians have difficulty. Guess what? It's easy to prescribe opioids. 5 minutes to prescribe, yes, and the patient is gone. 30 minutes to say no, because you have to find a place for the patient to go. You have to find psychotherapy, psychologists, cognitive behavioral medicine, or psychiatry. It's very time-consuming to deal with these people. And sometimes the patients have unrealistic expectations. They think that with this magic pill, their life will be better, their marriage will be better, their kids will behave perfectly, and everything will be happy in my life. So the physicians would say, okay, based on the evidence, by the way, how many randomized control trials do you think there are showing that opioids are effective for chronic non-cancer pain? We're talking about neck pain, low back pain, fibromyalgia, arthritis. How many?
Could you repeat the list of conditions, Andrea?
Low back pain, neck pain, arthritis, fibromyalgia, and neuropathic pain, like postherpetic neuralgia, diabetic neuropathy.
Very, very few trials, I would have thought. Very few trials.
And so someone around 10? Who thinks around 10 or less?
Less.
Zero.
Zero. How many think that are between 10 and 30? More than 30? 62. Okay, I did a meta-analysis, it's going to be published this year, and I published one in 2006. In 2006 there were 41. And from 2006 to now, we have 62. All of them high quality, because they are done by the pharmaceutical industry. Most of them very short duration, less than 3 months. Many compared to placebo, but many compared to other drugs, like compared to an NSAIDs, compared to antidepressants and convulsants. It's unanimous. They all show that opioids are very potent analgesics. They have a moderate effect size for pain and a small effect size for function, but compared to anything else that I know to treat chronic non-cancer pain, I would say they're the best. So they are very effective, but they have problems. We all have heard about the problems, right?
So Andrea,
Yeah.
it's a really, what you just said is really important. So that's systematic.
Everything that I said is very important.
Yeah. Great response. So the systematic review, has that been published, did you say, or is that?
The 2006 is published in the CMAJ that contains 41 randomized trials. The update is going to be it's already accepted.
So because it's chronic non-malignant pain, you mentioned the short duration. Is there good evidence about a sustained benefit of these treatments in comparison?
The evidence is very conflicting.
Yeah.
So all of these conditions that were included in these trials, they were chronic conditions. They were very chronic. They were having pain for years and years and years. And then they give opioids, they improve. Now, with the maintenance, a lot of people drop. So the reason why there are no big trials, longer trials, is because there's a lot of dropouts. These people, they drop out because of the side effects. So the ones that remain in the receiving opioids for months and months, they maintain some benefit. However, there's a lot of conflicting evidence, especially from the Workers' Compensation Board. They see people who receive opioids for many years, and they don't do well, they don't go back to work. So it's another topic. So goals, talking to the patients about the goals, what can these pills offer to you? So on average, these trials show that there are 30% pain relief. So it's unrealistic to think about 100% pain relief for everybody. So we have to talk to the patients and inform of their role, informing about the benefits, and informing their role in safe use and monitoring effectiveness. And then, if they decide to initiate opioids, they should initiate with a low dose, increase gradually, and track the dose in morphine equivalents, to do what we call a watchful dose. This was the first time that it was published in the literature because, as you all know, opioids, they don't have a ceiling dose. But in the guideline, we call this a watchful dose, which means above 200 milligrams of morphine equivalent a day, they should be monitoring the patients more closely, assessing if the patient is benefiting, if there are no risks, and if the patient is not developing one of the complications or overdose or medical complications or risks. Watch for any emerging risks and complications to prevent any bad outcomes, including misuse and addiction, and stop. This is new to the physicians. Physicians think, oh, it's impossible to stop opioids. No, we tell them it is possible to stop, to decrease the dose, taper, to switch to another opioid, or stop completely if the benefits are not more than the risks and the bad outcomes. What are are the gaps? What are a lot of things that we still don't know about opioids? So here is a long list. Urine drug screening. The guideline talks about urine drug screening, screening for the patient's urine to see if the opioids that you prescribe are there, and if there's nothing else that should not be there, like other opioids, or methadone, or benzodiazepines, or even illicit drugs. There's not a lot of good evidence to support that. Especially, there is not a lot of link between doing urine drug screening and avoiding addiction and diversion. There are a lot of things in between, but not a direct link between these two. The same thing with the treatment agreement. The guideline talks about it's a good idea to have a treatment agreement. We try to avoid the term contract with the patient. We talk about agreement. But there's no evidence that doing a treatment agreement with the patient will reduce the misuse, the abuse, addiction, diversion, and overdose of opioids. What about the opioid selection? We talk about, you will see here that there is a stepped approach for selecting opioids, but this is based on only sometimes the risk profile. There's not a lot of evidence suggesting that this is how you should do this first, and then second line, and then third line, because we don't have a lot of comparative effectiveness trials comparing opioids head-to-head. What about opioid administration? Do we know if suggesting people to do long-acting instead of short-acting is better, is more effective, is safer? There's not a lot of evidence regarding that. What is effectiveness? Are we talking about pain improvement, function improvement? Are we talking about costs, avoiding bad outcomes? How do we define effectiveness? And depending on where you are, you would like to see something different. Monitoring for long-term opioid therapy, as you also mentioned, we don't have a lot of trials suggesting how to monitor in the long term because the trials finish at 3 months. So everything that we suggest in the guideline is based, for all of these things, are based on consensus from this expert panel. So of the 24 recommendations, very few, 4, are based on randomized trials. The rest are based on either observational studies or consensus from that national advisory panel that was put together by the colleges of every province, 49 people. And if they approved a recommendation, it passed into the guideline. It had to have 80% approval from the national advisory panel to be included in the guideline. So that was a recommendation. What about collaborative care? We talk about collaborating with the pharmacist, collaborating, communication between the physician specialist and the family physician and the addiction specialist. But again, there's no good evidence to suggest this is good. It's good sense, but there's no evidence. What about opioid discontinuation? How to stop, how to taper, how to switch? Again, this is all based on observational data or expert opinion. Oh, it's cutting there. And what about psychomotor function? The guideline talks about, people who are on opioids should be refrained from driving a car when you are adjusting the dose. Once they are on a stable dose, they can go back driving, but the evidence is so poor. We did a review of the literature. All of this was done at the Institute for Kidney Health, and we didn't find good evidence to suggest that, although it's in the guideline. So talking about driving, this is one of the gaps, and that's what I'll be doing in my next probably 5 or 10 years of my life. Because this is what we have at Toronto Rehab. This is what we have right now. We have an IDAPT lab in the basement of the University Avenue and Elm Street. And this is a motion-based dome. So it's 6 by 6 meters. And you can put a car there. So you can put a car inside, and we're trying to get it right now. We're hoping that some donor will come and visit us and say, here it is, your $1.2 million for the half of a car. But at this point, what we need, what we are doing this is we can put people in a wheelchair, and this is, so there is a dome that projects whatever you want, the streets of Toronto, and then you put a person in a wheelchair and see, for example, if a person in a wheelchair receiving opioids with pain, are they doing mistakes, for example? Are they more drowsy, confused than a person in a wheelchair that doesn't have any pain and is not on opioids? Because, as you know, spinal cord injury leaves a person in a wheelchair, but also causes a lot of pain. It's a very common cause of neuropathic pain. So we'll be doing this there at Toronto Rehab. Despite many recommendations in the guideline being grade C, we know that, Roger Chu, who is the author of the American Opioid Guideline, he wrote this commentary, and he said, The best evidence in the Canadian guideline comes from the short-term trials in highly selected populations. There is a lack of effectiveness in comparative effectiveness trials in high-risk population, but until such studies are completed, the new Canadian guideline provides clinically sound recommendations for decision making. So, because we are now all about knowledge translation, so what we are doing now with the guideline in the last 1 year is knowledge translation, creating relationships with practitioners, with associations, with people, talking to patients, patients associations, to get everybody on board to be at least aware of the guideline, changing behaviors, and to achieve a better good for our patients and our population. So I don't need to explain to you, but knowledge translation is research itself. It's very important. Do you have a knowledge translation group here at ICES that worked on translating the evidence that you produce here?
We think so.
So the group that developed the guideline, the National Opioid Use Guideline Group, that group composed of the colleges, they also created a national faculty, which is now a group. It's different from the national panel that developed the guideline. Remember those 49 experts? Now the national faculty is composed of people who are interested in moving the guideline to practice. So implementing, disseminating, and evaluating the impact of the guideline. So we have people from coast to coast. We collaborate most of the time virtually, but we already had 3 meetings face-to-face. The last one was in May, last month. Oh, not this month. Today is the last day of the month. So the national faculty goals, first is to define targeted outcomes for the guideline implementation to promote the safe and effective use of opioids for chronic non-cancer pain. To develop an implementation strategy considering multiple audiences, contribute to creating a funding plan for implementation, and how to evaluate the impact of the guideline. So here it's a logic model of how we think we are doing. So to start, we have the document, the guideline. We have the members of the national faculty, where most of the people here are educators, people representing institutions, for example, representing the Canadian Medical Association, representing the Canadian Pharmacy Association, representing the Canadian Association of Nurses, for example. So we have all of these people together, educators, national partners, and the National Pain Center at McMaster, who is organizing and coordinating all these activities. I'll show you the activities soon. Our outcomes, the short-term outcomes, are first, to change awareness, attitudes, and knowledge of physicians, pharmacists, public and the patients, policymakers, and health payers. Medium-term outcomes is changing their behaviors. We hope that physicians will follow the guideline, the pharmacists will educate the patients, the healthcare providers, all the healthcare providers, they will have effective communication and collaboration. The public and patients, they will keep opioids secure at home, prevent diversion, communicate effectively with the healthcare providers, and the policymakers and health payers. They will create policy changes to remove barriers to appropriate care, including the other non-opioid treatments. We need other psychology, psychiatry, behavioral therapy, physiotherapy, physical medicine to treat the patients. So we need the policymakers on our side, and we need to convince them to do this. The long-term outcomes include outcomes and health. So patients will have improved function and less pain. There will be decreased addiction, overdose, and deaths from opioids. Chronic non-cancer patients will have well-managed side effects and complications. And there will be decreased non-medical use of the prescription opioids.
Andrea,
so, yeah?
It may be on the next slide, but the activities column at the moment is blank. Are you employing... You better fill it in.
Yeah. You want to see the activities now?
Yeah.
Okay. So we have created interrelated groups because we work together. So these are, we have the Eyes and Ears in the Field network. So this is headed by Lydia Hatcher in Newfoundland, which means is she's collecting primary care, people who are in the trenches, and how they are applying the guidelines to the practices, and bringing together this information to inform a future update of the guideline, changes in the guideline, or development of other tools. And the tools is me here, that's why I'm responsible for tools, not only this one, but many other tools. So if her audience, which are people who are using the guideline, could be pharmacists, physicians, nurses, patients, whoever, they need more tools, they bring to me, and I go around and try to find those tools. We are developing many more based on this information. Patient and public education, Janine from CAMH in Ontario. So they have a strategy to educate the public, to educate the patients, the families. So we are creating a version of the opioid management for patients and families. So exactly what is here, but from the perspective of the patient. Knowledge translation to physicians and pharmacists, Frank Kirby from Newfoundland. So we are creating online CME modules. We are creating educational material. We're trying to get this information to undergrad medical students, to residency programs. We are trying to influence the Royal College in the pain. There will be a pain fellowship. So we want them to use the guideline as the tool to teach opioids. And policymakers, there is a Ian Goldstein from Manitoba trying to talk to insurances, policymakers, compensation boards. And then lastly, we have the guideline impact evaluation, which is headed by Mike Allen from Nova Scotia, and we are trying to develop, so we have already applied for grants and to measure the impact of the guideline. I'll go through more of these activities
Can I ask
later.
you about a question about
Yeah.
these, though? I don't hear from your description, it's brief, the clear indication that you're using known behaviour change strategies in your implementation of these initiatives for the different stakeholder groups.
Yeah, that's because I can't bring you everything, but the documents are huge.
But
Then we
can you
have-
focus just for a second? Because we know that promulgating guidelines, we know that even feedback of personal practice only changes about 5–10%.
Let me just go over the other activities.
Right.
The other slides is all about knowledge translation, how we're getting this through.
Yeah, there's knowledge translation and there's true behaviour change. It's that key, because this is the key in this case. I think Don may have had it.
It's sort of it's an abstract question, but suppose you're really successful. How much money are we talking about here if you were just to multiply the size of the target population by their lifespans, by the direct daily cost of medications?
You mean, what would be the cost? Cost saving? Or the cost of doing these activities?
Not of the activities, of the direct pharmaceutical expenditures per year in Canada.
I'm not the right person to ask to answer that question. I don't know about how many. I know in one of the workers' compensation, so they spend 35 million in opioids. So.
And that's for Ontario?
So I don't know how much would be the saving. Because the other thing also, it's complicated to talk about cost and use, because the guideline tries to tackle two problems. One of the problems is a lot of people are using a lot of opioids and we want to decrease the use. But there's a lot of people who need to take opioids and physicians are not prescribing. So once, it's hard because when you analyze a database and you are being successful, you are not going to see the change because these people are receiving. That 1/3 of the family physicians in Ontario, they have a sign in their office, a red sign, I don't prescribe any narcotics, any opioids, which is inappropriate. So patients complain to the college and say, I need this medication, I have arthritis, I don't have any risk factors to become addicted. Maybe it's a 70-year-old, your grandma, that with a little dose of maybe one of the opioids, she would be doing much better. She would be fishing, she would be, doing whatever she wants. And her physician, and you know how hard it is to get a family physician, doesn't prescribe. So they complain to the college. So the college with this document is trying to encourage those 1/3 of physicians in Ontario to prescribe to patients who need them safely and effectively, but also to reduce the other problem. So it is complicated to analyze use. So I hope that the next slides will give you more illustration of all the activities that are going on in Canada.
Can you just tell us what the issue is with the physician who won't prescribe
Maybe
it?
I skipped that because I think everybody knows about it because it's in the news all the time. So the issue with opioids is a lot of people are dying of overdose of opioids. And the people who are dying are young people who are using this.
Attention please, attention please. We have a code pink M. Mike Wing, 4th floor, room 417. Attention please, attention please. We have a code pink M. Mike Wing, 4th floor, room 417, and a message.
So the issue of the opioids is They, especially when they're mixed with alcohol and benzodiazepines, they can be lethal because they can give you an overdose. And in Ontario, they have been second to motor vehicle accidents in accidental deaths. In California, they are number one. They surpassed motor vehicle accidents in accidental deaths. So, and these are prescribed by physicians. Most of the time, these patients die, and in the last month, they visited a physician who gave them a prescription. So we are trying to avoid that. That's the main, number one problem. The number two problem is the addiction services in Ontario. They are overloaded with prescription addicted people. So they don't have any problem with heroin anymore in Ontario. They have a problem with OxyContin. Second to alcohol. So alcohol is still the first one that comes to the door. The second one is OxyContin problem. Outside of Toronto, especially in the London area, every pharmacy has been robbed because of OxyContin. Every pharmacy. Okay.
Wow.
So it's a big problem. And Ontario is the capital of OxyContin abuse in Canada. And Canada is the third largest opioid user in the world per capita. First one, United States, second one is Germany, and we are the third. And it's growing. So what are the activities that we are trying? I should have put a slide about that, but I thought that people would know because it's almost every week is in the news. Professional interventions, we call this professional intervention, and we use the Jeremy Greenshaw's kind of a 10 list of activities. So I'll talk about each one of these and see how we do with the guideline in the last 12 months. So unfortunately, Jeremy showed that if you combine more than one, I always had the idea that if you do multiple interventions, if physicians hear from multiple sources, you get a bigger effect. But that's not what Jeremy showed. You see here the effect sizes, and it doesn't show here is more than 4 of this. They're all the same. But anyways, we are trying to tackle all these 10. We have done 9 out of 10. So in terms of mass media, about the guideline, especially the first week after the guideline was released, there were more than 35 media uptake. And you talk about television, Globe and Mail, websites, newspapers, everywhere. They were talking about the guideline. And I like this one specifically, this one and this one, because they say the guideline is tackling the 2 problems, the chronic pain problem, the undertreated chronic pain, and the misuse, the growing misuse of opioids. All the other ones, they were focusing only on the bad aspect of opioids. So in terms of number 2, educational materials, distribution of published or printed recommendations for clinical care, which means distributing the guideline and moving the guideline. As I said, the Canadian Medical Association Journal goes to every desk, and it was in the front cover talking about guidelines. So every physician, at least they have in their desks, the guideline that was in the CMAJ last year. But the website, we have received 43,000 visits from 135 countries, and these visitors paged to 74,000 page views. And of course, Canada was the number 1 with 32,000 visitors. United States second, but we had people from all over the world, even from Brazil. My friends in Brazil, I was talking there to them. And this is the usage. Of course, after May 3rd, which was the release date, it was much better, but it's continuous. It seems not, because you can't see the line here, but it's not dropping completely. It's not a. And the Opioid Manager, which is also in the website, has received 5,200 visits. And we, in order to download this document, for people who are watching this through the video, if you're interested in downloading, you just Google Opioid Manager, and it takes you to the page of the Opioid Manager. There's a new version in 2011 because we did a validation last year. And we also created, based on the feedback from people who use the Opioid Manager, they wanted a video explaining how to use it, how to fill this, each one of these fields. So we created a YouTube video that is done by an academic detailer in Nova Scotia. She has explained this Opioid Manager to more than 100 physicians in Nova Scotia, so she knows exactly how to do this, and there's a 10-minute video there that you can access through the website. These registered users are people who download it, and we have their address, their name, their email, their profession, and where they are doing. So we have a database of all the users of the Opioid Manager, and it's going to be translated to French, Spanish, Portuguese, and Farsi. These are people who are using outside of Canada and asking us to translate it. We also have a toolkit because, of course, just giving the guideline to people, who is going to read everything? So we created a toolkit. This is part of the toolkit, but it's not only the only tool. We have developed a brochure for patients. We have developed a urine drug screening tool, a benzodiazepine tapering protocol, instruments to assess function and pain, how to do opioid selection, titration, an opioid tapering protocol, and many others. We have created training videos to talk about opioids, especially how to talk about this, the most crucial points of this, of applying the Opioid Manager and applying the guideline. One of them, for example, is asking for a sample of urine. So we have a video that shows a behavior, how the physician asking the patients for a urine sample, and this is to model physicians' behaviors. Number 3, educational meetings. Of course, we have done many workshops, not only me, but all the members of the national panel, all the members of the national faculty, many people. They are going all over Canada, of course, talking about the guideline in lectures, rounds like this one, conferences, Canadian Pain Society, physical medicine, anesthesia, at least to create some awareness of the guideline. It's there, and it's being used as a basis for some curriculum teaching about pain, especially at the University of Toronto interfaculty pain curriculum, which is a 1 week called the Pain Week. The students there, 902 students, were together and they heard about the guideline. This is undergraduate. In Ontario, we have done community workshops, so I've been to 8 workshops organized by the colleges. These are half-day workshops, and half of the audience is physicians and half are pharmacists in their communities. We have done in these 8 communities about 700 people. And what's interesting is that a month later, we asked them if they had changed anything in practice, and if they had used the toolkit that we gave them. The toolkit is all the tools. 95% said that they made practice changes consistent with the 5 essential actions. Remember those 5 actions? 95% said that they are using the toolkit, and 63% report changing interaction with the pharmacist, which is one of the recommendations in the guideline is improving communication between physicians and pharmacists. So they say that 63% have made some changes in their communication. What about local consensus processes? These are people who get together and they understand that the problem is important, and they discuss how to appropriately manage the problem. So we have the National Advisory Panel, which was a consensus building process. It was so hard to get those 49 experts, people from all over the country, people with different perspectives, people who don't prescribe opioids at all, people who prescribe a lot of opioids, to get to consensus on what should be the recommendations of this guideline. And it was interesting. It was a very good learning process for all of us, and we are glad that the final product, although in some of the recommendations is a wishy-washy recommendation, trying to please everybody, but that's how as good as we could get. In terms of outreach visits, so I think this is this is one of the best things that we are doing, is using a trained individual person to meet with the provider. That's what Isabel is doing, the person in the video. She goes, she presents the guideline, the Opioid Manager, with physicians. And the good thing is that in Nova Scotia they have a prescription monitoring program, which they can see before and after if that physician has changed behavior or not. And if not, they can go back and say, oh, you know what, remember me? I asked you to change some things and you really didn't change anything. And so it's interesting how you could interact with the patient, with the physicians. So 2 provinces are doing academic detailing.
I think there's a question at the back. Chris.
Yeah, sorry. So the last 2 slides made me wonder, addiction and the addictive substances like opioids, they can sometimes be very morally polarizing. So I was wondering how that affected the efforts of the consensus building among the 49 people, and then also those individual outreach visits to physicians.
So
some people feel very strongly about and some people take like more, say like a harm reduction view towards addiction.
So I'll give you one example, and I hope that will. So we had in the National Advisory Panel, we had pain specialists who prescribe opioids because they see people with pain, and they know that giving that pill will help those people. And we also have addiction specialists who don't see people with pain, but they receive all the complications, the addicted patients. So they were saying, why do you prescribe this, you know? So we had these people together, and then we wrote a recommendation, for example, for urine drug screening. So the addiction specialists were saying, everybody for whom you prescribe should be screened for urine drug screening every time, every visit, everyone. End of story. And this physician says, listen, I know this patient for 30 years. She's 70 years old. I treat her since she was 35. I know her family. I deliver her babies. I'm just prescribing Tylenol 3, and she's doing fine. What about the costs of this urine drug screening? And, is this going to be a burden to my clinic? So the recommendation of urine drug screening almost didn't pass because we couldn't reach consensus. So the first Delphine round, it didn't pass. Second one, we modified the recommendation a little bit, didn't pass. Third round, and we wanted to make at least some statement about urine drug screening in the guideline. Third round, we modified a little bit more, and then it passed. So it was high, and that was one recommendation. Did that answer a little bit your question?
A little bit, yeah.
A little bit, yeah. Good. So academic detailing. So about this, so if you go to academic detailers, these are trained people, and they are trained by universities. They are trained by institutions who don't have any interest in selling these drugs. They are similar to the drug reps. They go and visit the physicians with some nice material, color material, and 5 minutes, 10-minute visit. They have very, very detailed message, and they leave the physician with a message. So Arts Files in Saskatchewan, they have trained some academic detailers, and they are doing academic detailing in Saskatchewan, BC, Manitoba, and Alberta, based on the guideline. And Dalhousie, they have already done 60% of the family physicians in the province, and 100 pharmacists. And their goal is to reach out to all family physicians in their province, with only 3 academic detailers. What about local?
Can I ask a related question? And that's that, how do you know when you're taking a good idea too far? Right? But this is like a tremendous amount of work on guideline promotion, right? No one's ever going to accuse you of being lazy, right? And yet, there is sort of a time and a place and extent for anything. How do you know when you're getting carried away with yourself at the expense of other things?
I think when each one of us reach our fatigue point. Because without funding, one of the subgroups, they came with a budget of $3 million, which is not a big budget, but where we are going to get this budget? Without a budget, without a funding agency for us, we are going to reach fatigue very soon, I think. But the thing is outcomes. We wanna change outcomes, and we want to see when we have reached good outcomes. I think when we start looking at, and those were in the outcomes there, if you remember those things, when we have less admissions to emergencies due to overdose, if we can track those things, overdose, young people dying, diversion, but these are very hard to monitor and track. And when we have better education and everybody's receiving opioids for a cause that is treatable and not on huge doses. So using that 200 milligrams as a flag, who are on 200 and above, do they really need to be there? Can you decrease this? I didn't talk about this, but there's a lot of complications with above 200 milligrams or more, like hypogonadism, like opioid-induced hyperalgesia, which is a new type of pain, and impotence in men, and infertility in women, and sleep apnea. They are dose dependent, and sleep apnea, we know there's a major risk for cardiovascular events. So the story is the picture is very complicated, but and we had the outcomes group, the one which is trying to measure outcome changes in Canada. In our last meeting, we spent the whole morning putting in charts. What are the things that we can measure, and what are the things that would be desirable to measure? What are the things that are ideal, and where we have the data to go after. For example, the prescription monitoring programs. it's easy, you can see what they're prescribing, but then you have to do something about it. Let me see if I can finish my slides. So in terms of local opinion leaders, we haven't done too much in terms of trying to talk to the local opinion leaders and influencing them so they can influence others. This is one activity that is not being so explored by the national faculty. In terms of patient-mediated interventions, as I said, the national faculty, we have this patient group, and they are committed to ensure that patients have information and they can help the physicians to be aware of the information. But we're just starting to deal with the patients. Audit and feedback, haven't identified any activity in Canada where we are doing this for this guideline. Reminders, hopefully with the implementation, we are implementing this to many EMRs in Canada. Hopefully with the EMRs, if you don't know, EMRs is electronic medical records, so physicians who are paperless, they don't like to use this. So we are converting this, implementing this into their EMRs, and hopefully with the EMR there will be reminders. So if the physician prescribes an opioid, the software will ask, do you know that your patient is also receiving a benzodiazepine? And did you know that the combination benzo and opioid is very dangerous to cause an overdose and death? So these kind of things. In terms of marketing, that's the professional intervention 10. The definition of marketing, which is a little strange, is the use of personal interviewing, group discussion like focus groups, or surveys of targeted providers to identify barriers to change, and subsequent design of an intervention that address and identify barriers. So I have done this with physiatrists in Ontario. I've done a survey. I brought them to Toronto to do a workshop to them, and now we're going to repeat the surveys and do more focus groups with them to see if they changed anything. Mike Allen he has done an electronic survey of Canadian family physicians, and now we just applied to CIHR grant to do a mail survey of Canadian physicians, including GPs and specialists, pharmacists, and nurses, because the response to the electronic survey was very low, and apparently physicians respond better to mail, not to email. So how can we improve guideline use? Of all the guidelines that physicians receive in their offices, we want ours to stand out. We want ours to be special. Why? Because it's ours. But the way we do this is to making the guideline more adaptable, usable, increasing the validity, the applications, communicating, accommodating their practices, helping in the implementation, and doing some evaluation of the impact. I'd like to acknowledge the National Opioid Use Guideline Group co-chairs, Rhoda and Clarence, the National Pain Center, which is the website where the guideline is, the national faculty members, the CIHR for 2 meeting planning and dissemination grants, my institutions, Toronto Rehab, Institute for Working Health, the Department of Medicine, University of Toronto. This is my email if anyone has questions, and I tweet about the guideline, all the activities going around the guideline, and activities going on for opioids and chronic non-cancer pain, I tweet. Thank you very much.
We've got time for some questions, although we won't go all the way to 2 o'clock. Yeah, right, thank you.
As you have mentioned, there up to now there isn't too much evidence on the non-chronic about opioid. So if later on there is more evidence accumulated, will you update your guideline, and will you also take all these kind of interventions, because I know that will cost a lot to keep the physicians or public up to date, or is there any other alternatives, more cost-effective alternatives?
Okay, that's a very good question. Thank you for asking that, because then I can talk about this. This guideline, the opioid guideline, was a chapter in a CPSO guideline that was published in 2000. So in 2000, CPSO, which is the College of Ontario, they had a guideline that was how to treat chronic non-cancer pain. And one of the chapters was opioid. And the other chapters were injection, intervention medicine, acupuncture, alternative complementary medicine, cognitive behavior, blah, 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 etc. because the most urgent one was the opioid. It was, people were dying and people were complaining and physicians were doing wrong things. So we took the chapter, and I was responsible for the literature reviews and developing the recommendations, and with the help of everybody. The colleges, once we finished this, the college gave the guidelines, the opioid guideline, to the McMaster University, the National Pain Center, and told them, now you are responsible for updating this chapter, the opioid guideline chapter, and doing all the other ones. And so the National Pain Center, Norm Buckley, who is an anesthesiologist at McMaster, he has now the responsibility of moving this forward, updating this when new evidence comes, and updating all the other chapters that were in the original CPSO 2000 guideline, because all those things are important. I don't know how, when he's going to start and what is the methodology, but hopefully he will use the methodology of systematic reviews and consensus-based. Thank you.
Right, David?
Okay, ask about regulatory approaches. What's happened? Legislation's been introduced in Ontario, and perhaps Tara, if you can mention anything that you know of about the impacts of a more regulatory approach on the prescribing of doctors.
Yes.
Tara and others have, I think, looked at the impact. So could you talk about regulatory approaches?
Yes, a little bit, yeah. So in Ontario, what happened in October last year, they passed the policy saying that we will have a prescription monitoring program in Ontario, similar what other provinces have. And how they're going to use this is to track the use of opioids in the province. So we know what's happening in other provinces because in Nova Scotia they have this since 1993. In BC they have PharmaNet since who knows when. In all the other provinces they have, and the colleges use this all the time. So how they're going to use in Ontario is still a black box. They say that once they have this data, only the ministry will have access, and they will take action. And then later, pharmacists will have the access to this database. They will communicate with the college, but then last one will be the physicians. So physicians will be the last ones to have access to this data. But anyways, how is this is it going to change a lot in Ontario having this? We don't know, because we know from other provinces like Nova Scotia, BC, and all the western provinces, it hasn't changed a lot. For example, in BC, they have PharmaNet, so they are able to monitor who is prescribing what, and also the physician who is prescribing opioids, they can access the computer and see if that patient has received another prescription of opioid in the last 30 days, in last year, so they know about doctor shopping. It's not so easy, because a legitimate chronic pain patient may have received a prescription of opioid in the last 30 days, but he didn't like, he went, filled the prescription, but he took one pill, didn't like it, so now he needs another one. So the other thing is it takes time, so they have to keep encouraging physicians to be accessing the database, because it takes time, especially if you are in emergency, you have to go log in and access, get the data from the patient. So physicians are not accessing all the time for all the patients. I was just on the phone this morning with a person from Massachusetts, where they have a prescription monitoring program, and only 275 physicians in the whole state, they are registered to access it. So even having something like this is not going to solve all problems. It's good to have, it's better than nothing, but it's not going to be the solution that is going to solve everything.
Tom, can we ask?
One last.
No, I just want to ask Tara.
Tara, you want to chime in, or you don't want to be put on the spot like that?
The perspectives of the work that you've been doing.
One of the other things I think, that they have been discussing is the potential to put flags and warnings when certain, for the watchful dose, for example, if that's exceeded by multiple times, if there's an extremely high dose that's chronically being prescribed, or if certain physicians are prescribing a lot of very high doses to their patients, having flags that would notify the ministry that maybe that's somebody that, a physician that needs some attention or academic detailing or something like that. So those are another kind of regulatory approach. It's a different type of thing, but may also have an impact.
And a visit to a physician, what impact does that have?
That was actually going to be one of my questions, so maybe that can be tied in. I think what Dave's partially referring to is we did some work with the CPSO looking at their opioid prescribing course and its impact, and it found that, in the first year after the course, there was this drop in prescribing, and then the next year it just kind of, there's this U-shape, parabolic kind of shape where it comes back to where it started. So my question was going to be, you know, within the first year of these guidelines, it's the anniversary, you've put a lot of energy and will likely continue to for a while into getting the word out and having these detailing initiatives. But what happens 2, 3, 4 years down the road, and how, do you have any ideas as to how this is sustainable? Because it's
We don't know, and in the world, we are the first ones to be doing this with opioids. United States, they published the guideline, but there's no knowledge transfer activity at all. They're not doing it. It's just published and hoping that everybody will, and people mention, people quote, people, you know, here we have the guideline, but there's no plan like the national faculty like this. We're the first ones in the world. So what is going to happen here? We don't know. We hope for the best. But things like this. So, for example, in BC, I went to teach a course. So the college identified some problematic prescribers through PharmaNet. They invited them to come to a 2-day course, and I was there talking to these physicians, and also it was not just a group of these physicians. There were maybe 9 or 10 identified within a group of 100. I could easily tell who they were. They were like this. I was teaching there. Because they were told to be there. So, and you know what happens, most commonly what happens after they have this, they are scared by the college. It's really scary. They stop prescribing opioids abruptly. Many of them say, they are the ones who put the sign, I don't prescribe more opioids, and they create a problem. Because then all those patients that they were prescribing before, they are left orphaned. They have them to start getting their, because it's not easy for a patient who was on maybe 400, 500 opioids morphine equivalent. Now, where do these patients go? They go to walk-in clinics, they go to emergencies, they go to family physicians, other family physicians, they are interviewed, nobody wants them, they go to pain clinics, so it's a big problem.
Okay, and on all that, and on that opportunity
Thank you very much.
for further research will end. Thanks very much.